Hello, 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 everyone, and welcome to this episode of the Global PAD Impact Awards through the Global PAD Association. Today, we are presenting the Registered Vascular Technologist of the Year Award for outstanding contributions in peripheral artery disease diagnostics. Peripheral artery disease, or PAD, affects just millions and millions of Americans, and accurate diagnosis is the critical first step toward effective treatment and limb preservation. The technologists we honor today truly represent what I would consider the gold standard in what this life-saving and limb-saving diagnostic work should be. It is with great pleasure that I announce this year's recipients, Victoria Ta and Lisa Myles of Hope Vascular in Houston, Texas. Victoria and Lisa have distinguished themselves through their remarkable combination of technical precision and compassionate patient care. Their mastery of advanced imaging techniques, particularly their expertise in pedal acceleration time measurements, which we'll hear more about in a moment, has enabled more accurate diagnosis for countless patients facing limb-threatening conditions. What patients say is each has the ability to provide comfort and clarity during what can be a really stressful diagnostic procedure. Patients consistently praise not just their technical skills, but their genuine compassion and their care. Their attention to detail also ensures physicians receive comprehensive vascular assessments, directly contributing to improved treatment outcomes and limb preservation throughout the Houston area. And today we are privileged, so excited to have with us, very honored to have with us, Jill Somerset. She is the inventor of pedal acceleration time and also our 2024 Diagnostics Pioneer of the Year. And she is joining me now to speak with Victoria and Lisa about their groundbreaking work. Thank you, Jill, for taking the time to be here and also helping me to raise these young ladies up for their incredible work.
Well, thank you, Kim. It's always a pleasure to join you and see you on this really nice dedication to vascular technologists. And I think this award is so suiting for two very extremely well-versed and technologists, Lisa and Victoria. What we do at Hope Vascular and Podiatry goes above and beyond, not only doing PAT and pedal duplex mapping, but really scanning challenging patients facing no options. So we have the privilege to work with Dr. Miguel Montero Baker, who is a renowned world expert in deep venous arterialization. And they scan his patients pre and post-operatively. And they pay attention to extreme detail, and they map these patients from groin to toe with precision. So it is my honor to provide this award with you, and it's great to have you both here.
Thank you.
It's so great. You want to tell us each just a little bit about yourselves and what drove you? I like this question better. Why do you have a foot fetish? Because
Maybe they didn't, but they do now.
Yes. Because with diagnostics, you have the whole body you could have selected, but you're literally doing legs and feet.
Right. So my name is Victoria. I've been a tech for almost 2 years now. I'm very new in the field, and I'm gonna be very honest. I did not know what I was getting myself into, especially with all this feet stuff. All these other, if you go to any other hospital, the vascular team, they usually just stop at the ankle. Here at Hope, we scan all the way to the toe and a lot more. And I've been here for a year now, and honestly, I really like it here. So I feel like I'm gonna be here for a while, scanning feet all day.
Wow, before we get to Lisa over there, Victoria, you said something incredibly alarming. And I'm curious, at your other hospital, you stopped at the ankle. Are you now, with what you have learned through working with Miguel Montero Baker and Jill Somerset, are you now just sitting here going, oh my God, how many more legs and feet could have been saved if only. Is it
Mhm.
disturbing now to look back and go, oh my God, how much did we miss?
It is. I mean, when I was a student, I went to not just one hospital, I went to multiple. And even in school, a lot of the programs now, they just teach you to really stop at the ankle, at most top of the foot. So I think pedal is something that needs to be spread along to everywhere.
Jill, I'm literally going to have a heart attack
I know.
because
It's
of
like
all the
music
leg
to our
attacks that
ears.
are going to happen, that are
Yeah.
happening because of this. I had no idea it was that big of a problem.
Mhm.
Yeah, and especially in our patients are becoming sicker and their disease is also in the foot, so we can't ignore that.
I mean, people who, I mean, we have this second type of pad. We've talked about this a number of times. I think you and I even talked about it, but on our podcast, just about the fact that there are two different types of PAD, peripheral artery disease, right? You have the textbook PAD that the number one sign is really the intermittent claudication. It's a bigger vessel disease, right? The thigh, the iliac vessels in the groin, and to the aorta. But we're seeing a lot more smaller vessel disease. This is what I consider kind of a type 2 PAD, that the first sign a lot of times for these patients, especially diabetics and chronic kidney disease patients, end stage renal disease patients, it literally is a wound that won't heal on their foot. And it's really concerning if the diagnostics aren't keeping up with the disease at a lot of these hospitals.
Yeah, absolutely. And I think Victoria and Lisa can also attest to the calcium burden that we can now appreciate with duplex ultrasound. We're not just documenting proximal, mid, and distal of vessels. We are looking at flow patterns, calcium burden. We are looking at these patients' disease pattern in a whole new light.
And I'm so sorry, Lisa. We got on a tangent before we could even get to introducing you. I mean, it's such a hot topic, and it's so important for patients to hear this and be able to say, hey, you know what? Wait a minute. I have a foot there that you're missing.
Mhm.
And Lisa, how long have you been with Hope Vascular? And what was your story before coming into Hope Vascular? How long have you been there?
I've been here 2 years, going on 3 years.
Okay.
And before I've been scanning for almost like 25 years. I'm from Ohio originally. And so I've always been an RVT. So with that, I've always worked around wound care, but we never went into the foot as well. We always stopped at the ankle. But then I went to Vanderbilt because I moved to Nashville. So that was about 4 or 5 years ago. And I worked there for 2 years and they had just started doing the DBAs.
Oh, they're doing that now. Oh, that's
Yeah,
amazing.
they Dr. What is his name, Jill?
Claire, Claire.
Yeah, Dr. Claire, who came from Ohio as well, came there and started doing the DBAs to
Oh,
Vanderbilt.
wow. Because I was told by a couple doctors that have moved, to the Midwest that went to Vanderbilt. I was told that they won't use rotor-rooting devices, no atherectomy devices there. So that's amazing. I don't know if that's true. I've never asked them, but it was just a
Mhm.
couple of doctors that had recently graduated and went through their fellowship, and they were just starting their own practices, that they said that they had to adopt it on their own because they hadn't learned it there. But it sounds as though
Yeah, Dr.
there
Claire
are
has started.
doctors there that are doing advanced work. So
Yes,
that's good to know.
yes, Dr. Claire started it.
Oh, was that just a few years ago?
Yes, within the
Ah,
past, because I've been here for 2 to 3, and I was there for 2, so within the past 4 to 5 years.
oh, that is excellent to
Mhm.
find out. So in coming to Hope, you probably weren't as surprised then. You were probably more skilled, and there weren't as many surprises coming into Hope Vascular because of your experience at
Well,
Vanderbilt.
the extent of wounds was a surprise. The extent of the wounds here are a huge surprise. I don't,
How
And
so?
Jill, you could probably explain it better because you're down to the bone. Like you have some of them, you have very little flesh, so they're just wide open. The extent of the wounds here are incredible.
Everything's bigger in Texas, I hear.
Well, and
I'm
I
not-
will say, Kim, and that's why these two are so well deserving. I mean, what we ask of them at Hope Vascular Podiatry is we wrap the wound, and we are getting in there, whether we have to use a sterile probe cover to scan over the wound, but we are right up in that wound scanning, trying to figure out disease pattern and give all Dr. Montero Baker the answers that he needs to make some decisions around the treatment plan. So one of the other really amazing things is the collaboration we have at Hope. These two are certainly open-minded. I throw a lot of information at them. I'm constantly asking questions, and it goes back and forth. So I really admire their willingness to do things above and beyond that traditionally aren't done.
Can you give me an example, each one of you, of a case where maybe the order for the test, really, and maybe the write-up going into it just was far off, and because of your thoroughness, because of your attention to detail, you were able to say, hey, Dr. Baker, you won't believe this. There's so much more here than you might have thought.
Um, I could say I actually had an example of that maybe last week. Our front desk, I mean, they're not trained as medical staff. So they do mess up now every now and then, schedule like a venous besides arterial or vice versa, things like that. Um, I feel like we have a good understanding of venous versus arterial, especially because we use PAT too. It's easy to just pop down to your feet, look at the PAT, and if it's class 1, which is a relatively good to normal flow, then we could say, I don't think this patient really needs an arterial. Of course, we also ask the patients like their signs and symptoms, if they have claudication, pain, wounds, things like that. And from just the questions also, we could kind of tell if it should be venous or arterial and adjust a test according to that.
I love that. So you just don't take it as it comes. We talked to Denise Levy, who also Jill knows, and she ended up with our Lifetime Achievement Award. She just retired after 50 years in diagnostics. She was one of the pioneers, in diagnostics for vascular. And she was saying that there have been so many times that she's gotten an order that has been for veins, and it was really arterial, or arterial when it was really a DVT. And you can't be afraid to speak up when it comes to these patients, because limbs are on the line in so many cases, and in some cases life is on the line. If it ends up being something that you should have done a venous for a DVT, and you're sitting here worrying about arterial, that could be a big problem. So you're that second set of eyes for these doctors. Do you have an example of that as well, Lisa, that you could share? I mean, you've been doing this for quite a while, so I imagine in 25 years, you might have one or two of those where you're like, hey,
Yeah,
doc, I don't think
right.
so.
I've gotten a few patients who have a wound, but it's not like on their foot or anything. It'll be like on the leg, and then they'll ask for maybe an arterial, and then I'll have gone in there and they had a DVT and reflux, which it was a venous wound. So yeah, because not everybody gets seen first. Sometimes they'll call in and then they'll just order a test.
And so we're basically the first people that see them.
Yeah.
Oh, yeah, fantastic. And I'm curious, just from your perspective, what would be a case in which you feel like you've learned the greatest lesson in your career that maybe other technologists, maybe even patients, could potentially learn from?
Hmm. Well, I think I've learned that even the worst wounds will heal. Like if you're just thinking that they're not going to heal, I'm wasting my time, but that's not true, because here at Hope, I've seen some remarkable wounds heal. Very humbling.
Is there any particular case where you've taken this patient personally and have followed their story from the very beginning when they didn't have hope and then they found Hope, do you like that play on words?
Yeah, I do have a few of my favorite patients here who have remarkable stories and who become friends. Patients here become friends with other patients here. So
Oh
that's
yeah.
nice as well.
Is there one story that stands out to you? Because I can tell there's one that's in your mind. I can tell
Yeah,
that one's coming to mind because you have this big smile on your face, and so I just think that there
I
has to
mean,
be.
you just watch somebody go through their journey. Like I watched Miss Trujillo, I don't even know if you could say their name, but I watched her go through her journey and then to see her go home and she doesn't come back for a couple of months. And I'm like, what happened? And then she comes in and everybody just gives her a hug and it says hello and everything.
See, there's that compassion
That
that we
says
know
a
about.
lot. Yeah.
Mhm.
And we had that. We have the chairman of our PAD Warrior Task Force, Douglas, that I was mentioning kind of before we started, and he just absolutely loves you guys and has nothing but great things to say. You make him feel comfortable, and especially when he's been brushed off by so many other doctors and technologists, and he feels comfort in the personalized attention and your attention to detail that
Mhm.
you provide throughout that entire experience. And what he loves is that you walk him through. You don't just do it, but you answer his questions. If he wanted to know every aspect of it, what you were seeing, what you were doing, and you're more than happy to share with him every step of the way and teach him about what you were seeing. And he was able to go back into our group and be able to share what
Mhm.
he learned from one of you. I don't know which one, but he said it was, he called it Hope Vascular, the diagnostic people there. So it was one of you or both of you. I'm not sure which. I'll have to ask him once he probably watches this. He's going, oh, I can tell you.
Yeah, it's only the two of us. Pick A or B.
A or B. How, I mean, you guys, in our scheduling, you're busy. I mean, this is, you're scanning legs from first thing in the morning until the evening. Does that ever get boring, or is it enough of a variance in cases that really keep your attention? And especially, I would imagine you have a lot of complex cases that require a lot of thinking, analyzing, and create that variance.
Definitely, I don't find it boring at all. Every patient is different.
Mhm.
And I mean, sometimes even when they come monthly, their scan is not exactly the same. So it's like you always have to be aware of what's going on when you're scanning and, really analyzing each picture that you take to really put the whole picture together.
Mhm. Yeah.
And I'm curious if Jill can ask some questions on, the pedal acceleration time. I want to talk a little bit more about the feet and have them share experiences, on in working with you on pedal acceleration time. But I want to get into details. I know we've talked about it before, but for those who are just tuning in, to talk about why it matters and you know, the difference between using it and not, both on a general diagnostic level, but also in the cath lab.
Yeah, so pedal acceleration time is an objective measure of blood flow in the foot where we can measure a waveform, and we measure that in time in milliseconds, and we have a criteria. So this is a really nice way to evaluate blood flow to the feet. And I think I have a question for Lisa and Victoria. Lisa, you have over 25 years of experience, and Victoria, you're newer into the field, but both of you were certainly willing and able to incorporate and learn into your protocol. How has it been for you, for all of the listeners, of learning PAT and implementing it into the vascular lab?
It was not hard. It was not hard at all.
Yeah.
Not at all. It was easy to learn.
Was there any aha moment with it for you where you're like, have I not been using this all along?
No.
There had to have been a patient where the light bulb went on and go, okay, this is worth doing.
Um, I think in general, it's just really nice to have, especially because when we talk about pedal acceleration time, it's easy to like go to Dr. Montero and be like, class 1, and he's like, good, patient's okay, stable. Whereas like if we didn't have PAT, then I would have to go in depth like, oh, for morals, this and this and this. But when you say just like class 1, it's like quick, it's fast. You know, he kind of understands what's going on with the patient. It's similar to ABI, but I personally like PAT better. I feel like ABI has like a lot of variables, like
And some limitations.
Yeah.
and limitations as well. So
And the nice thing is Dr. Montero has an OBL, so he does his procedures right there. And sometimes you get called in to do a post-op scan. Can you
Yeah.
speak to that?
Also, you always get
uh,
that.
like I said, like PAT is it's a fast scan. Like once you know what you're doing, it's like four spots on your foot. So especially after the patients leave from the OBL, it's really quick for me to just go in between patients to the recovery room and do a quick scan and tell Dr. Mateo if his procedure or intervention is working for the patient. Sometimes it does take time to see the immediate change, but a lot of times I do see the change. Like I'll drop down a class significantly.
Yeah.
Oh, that's kind of cool.
Mhm.
And so what about you, Lisa? Do you get called into the cath lab or get called into recovery to check those patients?
Well, fortunately, Victoria's on the same side as the cath lab right now,
Oh,
so she
gotcha.
gets the brunt of all of those.
So it's
On
like,
the other
Victoria,
side.
stop what you're doing.
Uh-huh.
Stop what you're doing. I need you now.
But if
now-
she's
Check
too
the
busy,
flow.
then I'll have to come over. And
But now
that's it.
Lisa, you're on the podiatry side with Dr.
Yes, I'm on
Lipo.
the
So we got
yes.
this really nice toe and flow model. Do you, where you get called from Dr. Lipo to do an
Yes.
add-on?
I get Dr. Lipo's add-ons and
Yeah.
Victoria mainly gets the things that's going on over here.
Are you doing the x-rays too over in Lipos?
I don't do the x-rays, but
You
they
just do
do
the
x-rays.
Yeah. Okay. You
Mhm.
just do the ultrasounds.
Mhm.
Okay. But you still do the full legs over there. It just depends on who's ordering them, right?
Every exam is the same. Every arterial, you're doing the full gamut. There's no shortcuts.
And so when patients make an appointment to have an ultrasound, you never know which way you're going to go, if you're going to go to the, to you, Lisa, or you, Victoria, on which
No,
side of the building.
no. They just schedule, and whoever schedule is open, that's where they go. Because we're equal.
Yeah. Yeah,
Kim,
that's
we should also talk about deep venous arterialization because this is a procedure that's becoming more common. For all
yes.
the listeners out there, this is patients who don't have any other option. So Dr. Montero and other physicians are connecting the artery to the vein and then delivering that oxygenated blood flow down the vein around the foot. But after that procedure is done, we really rely on ultrasound to understand the hemodynamics and to give the physician all of the information if that procedure worked. And so Lisa and Victoria both had to learn this new protocol and understand all of the hemodynamics. It's complex, but maybe you could speak to your experience learning something new, such as DVA.
So I've never ever heard of what a DVA was. It was not taught in school. Even the students that come to our clinic and we train them, they came from the same school I did. They still don't learn what a deep venous arterialization is.
Wow.
It's very foreign to them. I mean, a lot of hospitals, they also don't do them. Like I read a report from another hospital and they called it like an unknown stented conduit. So they don't even know what it is really. To me, it's learning to scan it is not hard. It's very similar to a fistula and kind of like a bypass graft. That's how I would explain it. But the idea of it is really cool. What I explain to my students in like simple terms, it's he's using the vein to transport arterialized flow to the foot and it creates new collaterals. that's basically how I explain it to them so that they can understand it more. But seeing like the angio before and after is really cool. It's
Yeah.
basically like a desert foot, and then afterwards you get to see like all these new little collaterals. And when I show them like that comparison, it like hits them. It's like, oh, this is what's going on, you know?
Isn't that amazing to see? Do you remember the first one that you saw and you were like, oh my God, this had nothing. Like this had nothing. It was a desert foot, no flow. And suddenly the doctor hijacks a vein, places a stent through it, and voila, the vein now acts as an artery and there's blood flow in the foot. And you have all of these, are they the collateral vessels that just have laid dormant, for a while, that don't have enough flow? You can't really see, they don't have much blood flow, but then they're just like whoosh, hey guys, you got to dilate. We need room. I don't know if I'm explaining it too simply, but is that kind of what you're experiencing or what
Yeah.
happens?
Yeah.
And so when they should teach these types of procedures, is what you're saying, in the schools, so that the students know the different types of scans that would be available. Because I would imagine, I mean, how often do you as vascular technologists end up being as involved in the procedures? Does that happen often? I don't know.
What do you mean?
Well, when you have a procedure, you have to learn the procedure, right? In order to understand what you need to be checking
Right.
and what the blood flow should be doing and how it may be different. I'm not sure if I'm asking it correctly, but how many other procedures do you as vascular technologists know of? I mean, I guess bypass procedures, you have to know the difference with grafts. So that's being taught, right? So you understand the bypass procedure, and
Right.
you're taught in school the different sounds and the different waveforms from that. So you're saying that they now need to include DVA in school because it's, a fast, adopting procedure.
Right.
Or a lot more doctors are adopting it, and a lot of technologists still don't know what they're looking at.
Yeah, at least be aware of it, right? Just
Yeah,
teach
be
some,
aware.
fundamental. Yeah.
Yeah, I
Oh,
think just like a introduction to it, because I mean, even when we just say, "Oh, I'm gonna scan a DVA," they're like, "What is that?" But if you were to say like, "Oh, I'm gonna scan an AVF," like that's a thing they taught in school. At least they know what an AVF is. But DVA, HISA, it's like very foreign to them.
But I actually don't know how big is DVAs, Jill, or are DVAs?
Yeah, I think more and more physicians are doing this procedure. I think our patient population is more complex, and that procedure is needed more and more. So I think we're going to see more of it.
So if a patient that's had a DVA, we've dealt with this quite a bit. So if a patient's had a DVA, they end up in the emergency room, they don't really know what they've had. We end up with a lot of doctors that just want to do amputations, right? They're like, oh, we're just going to cut it off, because they don't seem to understand. Is part of the problem that the vascular technologists that are in, a lot of these hospitals that may not be familiar with DVAs, that there is a different way that you do need to measure versus something that is standard and out there right now in a regular facility?
Well, what they'll do is if it's depending on if it has blood flow or not, if it doesn't have flow in it, they'll call it a clot. I have had that before. Like I've scanned behind another tech and they've called occluded graft or something of that nature. They've called it a clot, but it's not. So, and they're likely to do the same thing as far as like a DVA would go, because you will see a vessel and it won't have any flow in it, and you'll think it's just an occlusion. You may say it's a posterior tibial vein occlusion or something. You can say anything like that, not knowing that they've had a procedure.
We always tell our patients to make sure that you always have your records with you.
They need to
Um,
carry around a card, like one of those stick cards.
yes.
Mhm.
It's
Or
like,
even a bracelet that says DVA.
I really think
Yeah.
they should have a DVA card and say, this
Yeah.
was the procedure I had. And then on the back is a 24-hour number for the doctor that did it. So that if they go to the hospital, that the um, hospital doctor, the ER doctor, can actually get a hold of the doctor who performed the procedure to find out more and know whether or not there is a problem, if anything should be done, or if they do need to amputate. But most of the time, we find that an amputation is really not needed. But what's really disconcerting is hearing like there is so many variances in vascular diagnostics, and we hear from the patients all the time. They take their imaging as Bible, as gospel. Like, this is what I have, blockages, I have this, or they'll take it as gospel, as my doctor says the diagnostics are fine, there's nothing wrong. And then we go and get them to an accredited vascular lab, and lo and behold, they have non-compressible vessels, and they have pretty severe PAD. We had a guy that I was just talking to today. My day got away from me because I was spending a long time on the phone. Fascinating case up in the Seattle area, which I'm sure that Jill would love to know offline who these doctors
Yes.
were. The patient went to an ER during COVID time, and that was really crazy during COVID. The vascular, they didn't even send him to vascular, had an ER doctor that said, you just pulled a muscle, go home.
Oh,
Within 2 weeks, he ended up with a wound that didn't heal, got infected, and ended up septic and lost his foot.
Oh, that's tough.
And he was like, where did this come from? I thought I just had a pulled muscle. Then suddenly my foot goes, he has some sort of clotting disorder that still, they've never sent him to a hematologist for advanced testing. They've done multiple procedures on him, including the amputation, but yet not sent to hematology. And it's all below the knee disease.
oh.
And it's just so bad. Poor thing. So we're sending him to, another facility to get a second opinion, because he's like, now they want to do bypass. But as you know, a bypass, when there's no outflow.
Yes. Yes. It's tough.
That would be an interesting topic before we let you jump off here. I know you guys are busy, but can you talk about outflow just a little bit? Because we've been asked that over and over again. And I don't know if Jill would be more comfortable talking about that, or Victoria, or what is outflow? How do you measure it? What do patients need to know about that?
Yeah, well, when we think of outflow, if we're going to do any kind of procedure, whether it be bypass or opening up a blocked artery, we have to have open vessels beyond where we're opening up the vessels. So that's where the vascular lab is really helpful, because if a physician wanted to do a bypass to the ankle, we can be very helpful to say the arteries in the foot are open. Therefore, when you do the bypass, all that new blood flow that's rerouted in the bypass actually has somewhere to go in the foot. And the likelihood of that bypass staying open or working is really high, as opposed to someone who has a lot of blocked arteries in the foot. They have no outflow. If we did a bypass in that situation, it may not be the best outcome because the blood flow has nowhere to go.
Yep. So we always tell patients, you know what, you need to make sure there's outflow. Once they turn on the faucet, you need to make sure the plumbing below can support that extra flow. And some of the doctors will say, well, we're just hoping it'll reperfuse. We're hoping it'll dilate the collateral vessels. And they don't talk about that. No, there are actual arterial blockages below. They can't support the additional flow. And we just had a patient recently that had 2 bypasses in a matter of 2 weeks go down right away. And it turns out he's just going in, today is Tuesday, tomorrow, to get a second opinion from a doctor who is going to fix the outflow. There's just was no place for the blood to go below the landing
Yeah.
zone of the bypass.
Yeah.
So
And this, Victoria and Lisa can also speak to this, but this is the real value of the vascular lab and ultrasound is we can evaluate the tibial arteries in pretty good detail, and same with the pedal arteries, and we can give a lot of insight to what the outflow is. Would you two agree?
Yes. Mhm.
So I'm curious from your standpoint. I want to hear a couple shake your head stories from your experience. Um, Maybe something a patient said, something a patient did, weirdest. And I know, Lisa, you have to. I know you don't have just one. And
I
I'm
have
not going
a
to settle for just a yes, I do.
I have
And
a shake your head story. What
oh, good, good, good,
always
good, good.
amazes me is that people will come in here with severe PAD, you'll fix their problem, and they will not continue to stop smoking. I had a patient tell me, well, it took me 45 years to get here, so now I'm clean, so it's going to take me, so I have another 45 years to go before I'll need another procedure. And
Oh
they'll
my
be right
gosh.
back within a year or so for another procedure. I've had that
Oh,
comment
no.
quite a few times. Quite a few times. People think once you clean them out, they don't have to change anything. They can just keep going right along and everything's going to be just fine.
So, Lisa, tell me, because we have our smoking cessation group and we take, clips from other interviews and we show it to the people in the smoking cessation group to better paint the picture of different impacts, that smoking has, right, on the vessels. Can you describe the difference, between someone who, when someone smokes, like you can tell by their vessels. Are the vessels actually spasming in there if they've been outside and having a cigarette? Is there any difference that you kind of go, this person was just smoking? I can tell. I not only can smell it, but
Right. I
I
was
can
about to say more
see it.
so by the smell than anything. Not
Okay.
not by the visualization, but
Okay.
definitely by the smell. My whole room will smell like a pack of Newports or something.
Yeah, but I think, Kim, we can, by the waveform, there is a change in the waveform. So usually a patient smokes and that waveform changes. It becomes very resistive, almost like all the vessels clamp down with when they smoke a cigarette. So we'll see a change right after they've smoked a cigarette. If you look at the waveform right after, and then an hour later, it does change. So it speaks to, what that nicotine does to our vessels.
Oh, can I get a copy of those? So we can show them. They would love to see that there is a difference. I think that would be really impactful to show. Here's what a normal waveform looks like. Here's what your waveform looks like on before you had that cigarette. And here's what happens right after you have that cigarette. And then an hour later, what it looks like again. I think that would be
Yeah,
so powerful.
sure would be. And I think we could probably also talk about we'll talk about a superficial femoral artery in the thigh, but in smokers, sometimes it looks like big boulders of rocks of
Yeah.
calcium. Would you agree, you two? Like
Yes, definitely.
ultrasound sometimes can't penetrate those vessels because they're just so full of big calcified, I call rocks.
Yeah, what can you tell both of you, what type of disease, can you tell if they're diabetic or if they're a smoker or a former smoker just by
Mhm.
Yeah,
you can't
Definitely.
have
definitely.
can you talk about how you can tell?
So the big thing is if they're a smoker, it usually affects the vessels above the knee. So aorta, iliac, superficial femoral, and diabetic is usually below the knee. So sometimes I scan, I'll see like the rocky boulders like Jill was talking about. And before I even ask, or while I'm scanning, I ask them, have you ever smoked or former smoker, any of that? They usually always say yes.
Mhm.
So that's how I can
And
tell.
and
And then when you get
Lisa,
a smoker and a diabetic, Lisa, when we get both of those, these
There's one difficult scan for you.
yes,
that'll keep you busy the entire time,
yes.
right? All the way groin to toe.
Right.
Hmm.
We have a question though that is coming in. Maybe Lisa, you want to take a shot at this? If your feed from Peggy she's watching on YouTube. If your feet always go numb while walking, do you think a DVA would be something to consider, or is this just for open wounds?
DVAs are for wounds.
Yeah, that's what I hear as well, is that there are
DVAs
so
are for
many other procedures to open up arteries. There are different reasons, right? Why
Mhm.
your feet could be numb. I mean, especially if it's both, it could be coming from the back,
Nerves.
different areas, nerves. But one versus the other, they should be able, right, with vascular ultrasound, they should be able to pinpoint, well, is there a vascular problem that is causing this numbness in your foot? Are there blockages in your foot? And that's where the pedal acceleration time, I think, has truly changed the game. And there are a lot of patients that will tell me they have, numbness in their feet or burning or tingling, but symptoms are in the feet. And they go and they get their ABI or their ultrasound, and they only go to the ankle, and the doctors are like, you're fine. But we're seeing more and more, and I'd love to know if you have a case that you can share where it literally was a below the ankle disease. And if only they would have done pedal acceleration time like we did, they would have discovered that they have blockages in their feet.
Yeah, it's not uncommon to see.
It's not uncommon now.
Yeah.
Oh, wow. And a lot of these doctors, they'll still say that even if you do have these blockages in your feet, that unless you have an open wound, they're just not going to touch it because they're so small and fragile. But if you do have a wound, to Peggy, what they're saying is it's worth having the conversation with your doctor, even if it just gives you hope that there is going to be an option in case you do get a wound and it does become limb threatening, right? Okay. And I didn't get Victoria's funny story, your shake your head moment. So before we close out here, I want to get yours, but maybe we'll get Jill to round us out in the end with one of her favorites as well. But Victoria, go ahead. Share one of your shake your head moments.
I guess my shake my head moment is just kind of when the patient is not aware of the surgeries they had. I mean, I scanned a patient one time, I asked them before, like, have you ever got work done on your arteries in your legs, veins in your legs, anything to your legs? They're like, this one patient was, nope to everything. Right when I put the probe down, big bypass. I was like,
Surprise.
So I asked him more in depth, like, oh, do you happen to know that you have a bypass in your leg? And they're like, no, what is that? I'm like, so like it's when you have a blockage and they try to reroute your blood. And he's like, can you check if my other leg has it? And I'm like, okay, when I get to your other leg, I'll tell you. Put the probe down on the other leg, 2 bypasses.
No way.
And I'm just like, I mean, you had to have gone to a vascular surgeon. I'm like, do you not like have a yearly follow-up that you go to or things like that? Nope to everything.
That's crazy.
I have had situations where we have been in, and I've heard about that with stents. And I did have a patient just recently who was told that they did have a bypass, and the doctor went in and he was like, there's no bypass here. And yet he told the patient that there was a bypass. And I kept asking, I said, are you sure they said bypass? And she's like, yeah, I mean, I have cuts down my leg. Wouldn't you think there'd be a bypass there? I'm like, well, yeah, but the doctor says there's literally no bypass. So they must have gone in there, thought they were going to do a bypass, may not have had a landing zone, or something went wrong, but they still came out and said, no, we did a bypass. So strange. You just never know. And that's why I always tell patients, you got to ask questions. Just don't take anyone at their word. Look at your charts, get the case notes after every single procedure. Even if you have to go get a second opinion and have someone else read it, just it's worth having someone else review the chart. And we're actually launching, I would love to involve you both in our new series that we're going to be doing. It looks like we're going to try. I wish we could do it every week, but to try and get a commitment, it's hard. So at least once a month, we want to have a technologist come on and sign up to just where people can send in their scans. And we're not there to diagnose. We're just there because so many of these patients are now uploading their imaging to AI, to ChatGPT, to have them, and it's diagnosing them. And you know as well as I do, it's not really necessarily the imaging, it's the symptoms, right, that are going to determine the treatment. I mean, we have patients that are blocked groin to toe and they're fine. They exercise every day and they do great. They just are go-getters, right? No procedure needed. But some people will literally obsess over a small focal lesion in the SFA.
Mhm.
And they're not limited by lifestyle, but what about this blockage? What about this blockage? So what we want to do is be able to be a sounding board, number one, but number two is to be able to explain what certain things mean as they're reading their scan, and questions to ask their doctor based on what is the scan. So would love to involve our two top technologists of the year in that, in all your spare time, when you're not saving the piggies on the front lines, right?
That's right.
But as we end here, final piece of advice from each of you. Oh, wait a minute, Jill, I didn't ask you your funny story.
Hmm. Well, mine wasn't really a funny story. It's more of an interesting one that we could probably all relate to. This was a patient I saw who 1 week before I saw him went to the emergency department with a painful big toe that was blue, and his foot was cold. And they did an ABI that read it at 1.2, and the patient was discharged. Nothing to do. Uh, Patient came to me a week later, and now the tip of the toe has gangrene. And so I scanned into the foot, and it's all thrombosed with fresh thrombus. He had a popliteal artery aneurysm that was showering. And that kind of just shows you, we can't just stop at the ankle. We have to look at the entire picture. It turned out the patient had a popliteal aneurysm repair, and we were able to save his toe. But yes, it was multiphasic at the ankle, but it had a large tarsal branch. But the entire dorsalis pedis artery going to the top of the foot was all thrombosed and clotted. So it's luckily it turned out okay for the patient, but it could have been really devastating.
Oh yeah, we've heard quite a few of these cases. I just had a patient come to me the other day with a popliteal aneurysm, and they were asking one of the doctors that we had on about it. So very
Mm.
interesting. And
Mhm.
Joshua, I think is that Joshua? Yep. Has a question here. Have we seen the age range change, perhaps showing signs of PAD earlier? Are you seeing
Oh
younger and
yeah.
younger patients?
Oh yeah. I think with diabetes,
Diabetes,
we're seeing and renal failure. Yeah, I agree, Lisa. Yeah.
Oh, that's so sad. So sad. Okay, so since we are seeing so many younger patients and just lots and more patients with PAD getting diagnosed, especially as we're raising awareness, what is the best advice you have that comes to mind for patients in choosing a vascular lab or making sure that they are getting the most advanced scan? What should they be asking for?
Um, I think when they're choosing a lab, it's not, it's kind of like shopping. Like you want what you want is best. You don't pick whatever you just see first. I think it's good if you go around, find a doctor that fits you, listens to you and your needs. I had a patient few days ago where she said she went to multiple doctors. They couldn't find anything wrong with her. And we did a test on her and we did find something, like we listened to her and we did every test possible. And she really appreciated that. She was
Yeah.
trying to find a doctor that would listen to her because she would tell the doctor all these symptoms and all the doctors say, well, your imaging's normal, like, this and that. But when she came to us, we did a different imaging, not exactly what they did, but we were able to find her problem. And
Nice
so,
work.
mhm.
Yeah, that's amazing. What about you, Lisa?
Basically the same thing. Find somebody that's really going to listen to you. not just try to get you in and out, but listen to your symptoms and give you feedback so that you can tell that they're actually listening to you. So yeah, you have to do that.
And Jill, I know what yours is. Make sure they do pedal acceleration time.
Yes, I don't need to talk. Thank you, Kim.
No,
Yep.
but I do have a piece of advice for you, which I think would be really cool, is we have our PAD testing, padtest.org. Would love to include on there every single site that's doing pedal acceleration time.
Oh,
Yes, I would love to share that.
Because
Be
I
really
think
helpful.
I think we have 500 to 700, that are on there that are
Mhm.
just doing a basic, diagnostic in the primary care lab, but it'd be great to take it a step further and also include those that are doing the pedal acceleration time.
Yeah.
To raise awareness. So if patients, are like, something's wrong with my foot. I don't know. No one's finding anything, and they can go to a lab that will go the extra mile for them, and maybe they'd find something different. So let's do it.
Yes, amazing.
So thank you so much, Jill Somerset, for being here. We really appreciate
Mhm.
you, and congratulations to Victoria Ta and Lisa Myles of Hope Vascular, our vascular technologists of the year for 2025. Thank you for
Mhm.
all you do
Yay.
to help
Thank
save
you.
life and
Mhm.
limb.